We will all admit that our practices do have patients that are not eligible for immunotherapy. We do have
overall. That's a different group.
Tiziana to talk about ECOG 5508, which was really interesting 10 years ago. We are finally going to see data at this. It's still pertinent to practice, right? We would all agree that.
Right.
Tell us about it.
Okay, so E5508 is a cooperative group trial, and it's a study that really sought out at the time to identify the optimal maintenance therapy for patients with advanced non-squamous non-small cell lung cancer. So this was a phase 3 trial that randomized patients after completion of induction with carbopaclitaxel bevacizumab to Bev or Pem or the combination of Bev and pemetrexed. And ultimately, what the study initially we're seeing in the abstract format is that the combination of pemetrexed and bevacizumab did not show an overall survival benefit. And we'll hear more at the session on Monday. Dr. Ramalingam from Emory will be presenting that data, so we're excited to hear about it. I think it still is relevant. I think it was something that in real life we have really thought about that question, and there are patients that don't get immunotherapy because there are contraindications. And I would say it still is about 15 to 20% of the population. I think we're going to hear more about patients with autoimmune diseases, but that's a population that we have in our clinic that we still don't know the real answer of, are they eligible?
Right. It's a substantial proportion of our patients, for one reason or another, cannot get immunotherapy. And I think these data are still applicable, they're still relevant, and they are incredibly mature. We're talking about a median of 4 to 5 years follow-up. So we actually are going to see 5-year data as part of this trial. And I think because the details of the study are embargoed, what we know in the abstract does not include that, I think we have the potential of being fairly impressed. There's one other trial from Japan that was essentially a similar design, but it used a different foundation regimen. It was not Pac-Carbo-Bev, but Pem-Carbo-Bev. And for many of us, that reflected our practice before the immunotherapy era. And again, it was a randomization of Bev plus pemetrexed versus a control. And the incorporation of PEM plus Bev in those who had an established EGFR wild type. So again, a potential group that we know about. We didn't know about in the era of 5508. We weren't routinely testing for EGFR, but certainly in East Asia, it's part of the standard. In a subpopulation there, they did in fact see a survival benefit. So there are nuances here that I think we still need to explore. As a general principle, it appears that single agent, either one, Bev or Pem, probably de facto equivalents in the maintenance setting. We should give some sort of maintenance if we can. The combination we probably can no longer argue for routinely, although in selected patients one might make that argument, and I think that needs to be explored further.
Yeah, so I might disagree with you a little bit. I mean, because I think the era of the switch maintenance is behind us, right? But I think that for patients who have been on carboplatin, pemetrexed, bevacizumab, which was the Japanese study using that backbone, and then the continuation maintenance question of bevacizumab or pemetrexed bevacizumab, I think for patients who aren't getting immune therapy, that's still a very relevant question.
Oh, I agree. Oh, yeah.
And that study in the, they did pull out the only the EGFR wild type, but they had a very small number of patients with EGFR mutations who went on the study. It was less than 10%. So just sort of taking that section out, the majority of the patient on the study looking at that subsetted, but it did have a significant benefit of the two drugs and not just bevacizumab.
A historic trial, Avipril, that really asked the same question, significant PFS benefit, no OS benefit overall, but it was underpowered for survival. It really wasn't primarily powered.
Maybe a trend.
So it's clearly a trend.
Yeah.
So this is still something of an open question. I personally have patients in my clinic, they are getting to know each other, who are long-term survivors on some sort of maintenance. Usually started out as a combination for one reason or another, either logistics or some cumulative toxicity. Many are just on one agent, but my record is 10 years and counting.
Yeah, I've got some long-term patients too, and I think where that it's going to be very interesting because in my practice, the patients who are most often to be getting carbo, pemetrexed, bevacizumab RMI EGFR mutation disease patients who have already been through their EGFR inhibitors and any trials, right? Where sometimes we talk about Empower 150, but don't want to lose hair. We know the VEGF inhibitions. So that's still often a very common regimen. So it's interesting that maybe that group doesn't need that pemetrexed maintenance, but subsets of one study.
Certainly before Empower 150, my go-to regimen in TKI refractory patients was bevacizumab in combination generally with pemcarb.